Good afternoon, everyone. I'm Nirav Shah, the director of the Maine CDC. I'm pleased to join you all to talk about where we are with respect to COVID-19 for the entire state of Maine for today, January 5th, 2022. It's a happy new year, everyone, and I wanted to take a moment to offer our best wishes on a new year. Welcome to the first media briefing of 2022. Unfortunately, I begin today on a series of very sad notes. Maine CDC is today reporting 26 additional deaths associated with COVID-19. 25 of those 26 deaths were from our regular ongoing vital records review process. And those 25 deaths are those that occurred in the first half of December of 2021. These additional 26 deaths bring our total number of deaths in Maine to 1,582. I'd like to take a moment to offer my deepest condolences to the friends, family members, and communities of all 26 of these individuals. Overall, across the state, there have been a total of 149,543 cases of COVID-19. Represents an increase of 1,326 cases from just yesterday. Right now in the state, there are at least 382 people who are hospitalized with COVID-19. Now, to put that number in a little bit of perspective, especially as we are thinking about the Omicron variant, 2 weeks ago today, there were 375 people in the hospital. Today, that number is at 382. Of those 382, 117 today are in a critical care unit bed. 2 weeks ago, that number was 124. And ventilator usage, the number of patients who are on a ventilator, has been largely steady in the past 2 weeks. Today, there are 59 patients in Maine on a ventilator with COVID-19. 2 weeks ago, that number was at 60. Statewide, there are 45 available critical care beds for adults and 10 available critical care beds for pediatric and neonatal patients. Right now, across the state, 70% of people who are in the hospital in Maine with COVID-19 are not fully vaccinated, 70%. In terms of testing, our 7-day PCR positivity rate is now 18.05%. This is by far the highest it has ever been in Maine throughout the pandemic. It tracks what our regional neighbors are also seeing in terms of their positivity rates. Indeed, across New England, the entire region is seeing a similar sharp increase in positivity rates. In New Hampshire, their rate stands at 20.4%. In Massachusetts, 21%. And in Connecticut, 24%. Now, these numbers come at a time where, at least in Maine, testing volume remains high. For PCR tests, we are conducting 624 PCR tests for every 100,000. Though that's not the highest rate it's ever been, it's definitely still on the higher side. That's another way of saying that what's driving things like the positivity rate right now are the number of positives being reported every day, not a contraction in the amount of testing that's happening. Now, much of this increase in positive results on a daily basis is Omicron related. Although we are still officially at 8.75% of all positives in the state being Omicron, we know that this is an undercount. Indeed, likely a dramatic undercount. Based on data that we've received from laboratories across the state in recent days, the prevalence of Omicron is certainly much greater, such that the Omicron variant is well established at this point. The question for Omicron is whether the graph of cases that it generates will look like a giant wave, like the Delta variant, or like a sharp icicle, rising very quickly and then falling very quickly, as happened in South Africa. We still need more data from the state of Maine and from the United States to get a better handle on that question. Other countries, for example, the UK, are a bit ahead of us in epidemiological terms based on their experience with the Omicron variant. The picture in some of those parts of the world is becoming more clear. As it does, we'll have a better sense of what the Omicron variant means here in Maine. Now, speaking of testing is really hard to find right now in Maine and across the United States. I acknowledge that. I want to announce today one thing that we are doing to make testing just a bit easier to access. We are opening a drive-through testing clinic at the Augusta Armory. This will be PCR testing and will be available on an appointment-only basis. The first appointments will be available on Monday, January 10th, beginning next week. This clinic is being organized and operated by the Maine CDC, the Maine Emergency Management Agency, and the Maine National Guard. It builds on the successful experience that these groups, our groups, have had with vaccination clinics that have been ongoing at the Armory for more than a month. More information on how and where to sign up for a testing slot will be available soon on our testing website, as well as through various social media channels. If you're not able to sign up for a testing slot online, we are also working with our community vaccination hotline such that they too will be able to schedule appointments when those appointments are ready to go. We're going to be doing testing at the Armory on days when we're not doing, generally speaking, on days where we are not doing vaccinations. That schedule will change as events are needed at the Armory and that space is being used. But generally, we are hoping to offer testing at the Armory on days where we are not offering vaccination. Much more to come on that in subsequent days. Turning for a moment to vaccines and vaccinations. Right now, across the state, Maine is administering 4,812 doses of COVID-19 vaccine every single day. And as of this morning, 76% of everyone in Maine, from 0 to 100 and 100 over, 76% of everyone in Maine is fully vaccinated. Indeed, of those who are fully vaccinated, 45% are boosted. We still have more work to do on the booster front, but these vaccination numbers put us in good stead. More Omicron spreading across the state. And finally, just a few more notes before I wrap up today's diatribe. I want to take a minute to talk more about boosters. Earlier this week, the US FDA expanded the emergency use authorization for Pfizer's COVID-19 vaccine in 3 important ways. The first is that the US FDA authorized providing boosters for children between the ages of 12 and 15. Now, folks recall that 12 to 15-year-olds became eligible to receive their primary shots last year at the end of May. That means that many children in that age category are starting to be ready for their boosters right now. Indeed, the vaccination site here in Augusta at the Armory began offering boosters to this age group yesterday. In the coming days, additional sites across Maine will be expanding their own vaccine offerings to include boosters for 12 to 15-year-olds as well. The second change earlier this week was that the US FDA announced that it is shortening the interval after which people are eligible for a booster shot, moving it to 5 months post completion of your first shots, down from 6 months. This applies to everyone 12 and over. Now, those who received the 1-shot Johnson & Johnson vaccine are still urged to get a second shot of either J&J, Pfizer, or Moderna 2 months after their first shot. But this change, going from 6 months to 5 months, means that those who got the Pfizer shot initially need not wait for 6 months before they line up for their booster. Indeed, this applies to even those kids 12 to 15 who got their first shots at the end of May last year. So moving to 5 months down from 6 months. And finally, the third change. The US FDA authorized a third primary series dose for certain immune-compromised children who are between the ages of 5 through 11. What does all of this mean for you? Well, first, if you're the parent of a child who's between the ages of 12 to 15, and it's been 5 months or more since their second shot of COVID-19 vaccine, we recommend that you make plans to get your child a booster. And if you yourself got your second dose of the Pfizer shot at least 5 months ago, now is the time for you to get your booster. If you're looking for a spot for where to find a booster, go to excite.com and search for State of Maine COVID vaccine site. And that'll take you to a Maine state site that lists where booster shots as well as primary shots are available and being offered. So with that, I'm going to turn things over to our colleagues in the media today. And the first question goes to Patrick Whittle.
Thank you very much. Wanted to make sure I understood the percent positivity count. Did I hear that it was 18% and that is a high mark for the pandemic?
That's correct, Patrick. That is correct as to the number, as well as to the fact that it's a high mark for the pandemic, driven largely by more positive results, not a contraction in the amount of testing. Every single day in the past several days, over the past week, Maine CDC has been receiving more and more positive case reports of people who have tested positive every single day.
Got it. Following up on what you were talking about boosters moments ago, the University of Maine system announced today that it's going to be requiring tests from students who have not yet received a booster starting in the spring semester. I know that's a decision made by a body independent of the Maine CDC, but is that something that residents of the state of Maine can expect to see more of, tests for folks who have not received a booster shot yet? Or are there other arenas outside of higher ed where that kind of requirement could be turning up?
Well, it does vary by arena a bit, Patrick. In certain settings like healthcare, for example, there's still testing going on of employees. But generally speaking, what we have found is that, here we are more than a year after vaccinations were introduced. Owing to the natural processes of the body and its immune system, without a booster on board, some of the protection that you may have enjoyed from the vaccine in the first days, weeks, months after getting it does wane, partly because of the passage of time, but also because of the Omicron variant. Getting a booster is more important than ever. The rationale behind some of the decisions, like the one you referenced from the university system, is in recognition of the fact that without a booster on board, the protection that you get from the vaccines, although it is still extremely good at keeping you out of the hospital, keeping you alive, keeping you off a ventilator, it's not as good as that with the booster. And that explains the difference in why testing recommendations may start going in that direction. If you're boosted, no testing. If you're not, then there's still a little bit of risk.
I see. And one final thing, some sources have said that while cases are surging in many places right now, it's possible that 6 or 8 weeks from now, things could look much better. Prime Minister Trudeau has said this about Canada, which shares a long border with Maine. Some folks in academic healthcare have said that it's reasonable to think that in the late winter and spring, things will look much better. And I would like to know I know that you want to think that, but putting all emotion aside, do you think that?
Patrick, I got out of the prediction game a long time ago, as you know, and partly because the modern history of COVID has been marked by individuals who made predictions of that sort based on hope and have turned out to be wrong, unfortunately. But that prediction is not without some basis in the data. That sharp icicle-like growth curve is what has been observed in South Africa. However, South Africa differs from the US in certain meaningful ways. The younger population, higher rates of prior disease. It really is too early to tell. Obviously, I hope that we go in that direction. I want us to go in that direction, but I'm prepared to be wrong on that. That's one reason we're bringing more testing online. We're trying to take steps to make it easier to get tested, as well as to make it easy to get your shots.
Okay, thank you very much.
Yep, thanks, Patrick. Let me go to Amy Brown next.
Thank you, Dr. Shah. Do the numbers that you're reporting, I assume that the answer to this is yes, they still only represent PCR tests, correct?
No, these represent both PCR as well as antigen tests that are reported to the Maine CDC. So certain testing outlets, and certain groups that receive antigen tests from the Maine CDC are required to report those results to us as part of the deal. For example, if you go to Walgreens and get an antigen test there, not the one you purchase, but the one you sign up for, that you can get for free at many Walgreens. Part of our arrangement with Walgreens is that they report those results to us. So they include both antigen and PCR tests.
Okay, and the antigen tests, if you knew of them, I think used to only be considered probable until they were confirmed by a PCR. Is that no longer the case?
No, that remains the case. That remains the case. Mm-hmm.
So do anyone have any sense of how many positive cases are out there that were done by home tests that were never, those aren't necessarily communicated to your office? How much bigger is the picture than what you're aware of? Do you guesstimate?
Well, we don't guesstimate, but we try to model based on what we know, and it changes throughout the course of a pandemic. There are different models that we use to interpolate what might be going on in the pandemic based on the fact that in no outbreak or no pandemic in history have we tested every single person in the population every single day. And so there are models that use, for example, the positivity rate as a proxy for how much bigger the bottom part of the iceberg has been. You are correct. Right now, where we are with respect to COVID-19, home tests are not reported to the state. But that doesn't mean we don't know what's going on. That's one reason we focus on the metrics that really tell us what's going on. One reason our team really focuses on things like hospitalizations, intensive care unit utilization, and ventilator utilization.
Okay, and just one more quick question about that, and then I have another one. Do primary care providers report cases to the CDC if someone is tested at home and lets their PCP know?
So COVID-19 remains a reportable condition by those who are required to report, no different from if it were measles, HIV, a number of other reportable conditions.
Okay, so you have that included in those numbers. Thank you. We haven't heard any news on outbreaks recently. What's the CDC's role in dealing with outbreaks these days? And are there any of particular concern or any large ones in the state currently?
Our role with respect to outbreaks hasn't changed. We continue to work with facilities, workplaces that are experiencing outbreaks to make sure they've got what they need, be it from a PPE perspective, a testing perspective, as well as an infection control perspective. So that work and our role there has not changed.
And any large outbreaks that or any of particular concern right now that you're working with?
There are a number of outbreaks that our field epidemiology team are working with. None in particular, however, to shine a spotlight on.
All right, thank you.
Mm-hmm. Let me go to Brian Sullivan next.
Thank you, Dr. Shah. We were at a couple of the vaccination clinics that were, I believe, in Dexter, maybe Dover Foxcroft today. And I just wonder, I know in the past you've talked about hosting clinics in maybe more rural locations like that, but needing a partner. Any thought, maybe it's already happening with the Maine CDC, to be proactive and try and find places to have these clinics in some of the farther reaching parts of the state?
Oh, you are correct, Brian. It is a priority and has already been happening. We've got clinics that are ongoing, as you noted, today, right now, in Dover Foxcroft, as well as in Dexter, working with a partner there. We've got a number that have been happening in and around Southern Maine in partnership with a community pharmacy there. We are always looking for places where we think people will be, where we can offer vaccines. Sometimes we do so, we conduct that outreach with civic organizations to approach them to say, hey, is there a place in your community where you think people would be that we could get them vaccinated? Sometimes we do that outreach with providers like community and independent pharmacies. So that work is ongoing. We haven't slowed that one bit. The last part of that, Brian, is schools and school-based vaccine clinics, which were a mainstay of our approach the latter part of last year. We're looking at where we go with that in the beginning now of this year.
Okay. And this is a bit broader, and I don't mean to be Eeyore here or anything like that, but we get a lot of are you discouraged at all by where we are in 2022 with the availability of vaccinations and just an 18.05% positivity rate? It's just you hear a lot from a lot of different people, and I just would love to hear how you feel at this point in time. Well,
first of all, Brian, it's okay to be Eeyore. We're in the fourth calendar year of a pandemic, and indeed, the name of Maine CDC's softball team should be the Wet Blankets. That's just kind of where we are right now. Am I discouraged? No. I'm not discouraged. Because here's why, Brian. There's you didn't say this, but there could be someone who hears that question and takes from it that we are in the same place that we were in March of 2020. And woe is us, so little has changed in the pandemic. In one respect, I get that, right? The positivity rate today is the highest it's ever been. Hospitalizations are on the near or close to the highest they've been, although not the highest. And we're staring down a variant that is going to be spreading a lot more. So I get why it would be easy to go toward that degree of resignation, but I don't think it's accurate. The vaccines that we've got are widely available. To your point, I am not discouraged by the availability of vaccines. They're available in every corner of virtually every state, if not every state in the country, including Maine. They work spectacularly well. I mean, if anything, the undiscussed story of the pandemic is just how good the vaccines work at what they were designed to do. Keep people alive, keep them out of the hospital, keep them off a ventilator. On top of that, we've figured out safer ways to do things that are of primary societal importance, like keeping kids in schools. So am I discouraged? No. Are things the way that any of us would have wished them to be? No, of course not. But we're not in a position where we were back in March of 2020.
Okay, thank you.
Megan, let me go to you next.
Hi, thanks for taking my question. So with case counts being where they are, the rate being where it is, some experts have said that we should be focusing more on hospitalizations when we try and gauge the metrics where we are in terms of the pandemic and severity. What are your thoughts in terms of, should we be paying as much attention to case counts as maybe we were a year ago or even 2 months ago? Has that changed at all?
Yeah, that's a really great question, Megan. And I will speak for myself as well as for counterparts of mine in other states across the country with whom I have had the chance to have a very detailed conversation about the metrics that we should be using at this point in a pandemic. And speaking both for myself as well as to reflect what many of my counterparts have noted, as we learn more about the pandemic, as well as you noted, increasing case counts, higher degrees of community transmission, the metrics that tell us more on a day-to-day, week-to-week, month-to-month basis are less and less daily changes in case counts and more what we know about hospitalization, the fraction of hospitalized patients who are in the ICU, and the fraction of those patients who are on a ventilator. That is not distinct or radically different from the way that we conceive of many other respiratory diseases, like, for example, influenza, where the focus is on hospitalizations, pediatric and adult deaths, so on and so forth. There are a number of reasons for this, which I won't go into now, but only to mention that this is not to suggest that states or the federal government are abandoning the seriousness with which we conceive of COVID. That's not it at all. We're just searching for metrics that better and more granularly tell us what's really going on a day-to-day basis. With so much community transmission happening and so many individuals getting affected, what can we look to that tells us day to day what has actually changed? What's gone up, what's gone down? To put it in more technical parlance, what's a signal and what's noise? As we learn more and more about COVID, it becomes increasingly the case that hospitalizations, albeit not perfect at all, are a better metric of the day-to-day changes in the pandemic than things like cases, case counts, and arguably even positivity rates. For example, to go back to a theme that Amy noted a moment ago, with more and more people testing at home, what does that mean for those who are going to get PCR testing? Those are the reports that get reported into our positivity rate. All of these questions have to be factored in, and when you really think them through, hospitalizations are probably a better marker. I will tell you that's what our team and I really focuses on these days.
Thank you.
Mel, over to you.
All right. Thanks, Dr. Shah. My question is, especially because there's not a lot of appointments available, a lot of people are turning to those at-home tests, but are those at-home test kits effective at detecting Omicron?
Yeah, great question, Mel. Answer is yes, particularly if you are symptomatic. So let me just start with that. There was a little bit of data, or not even data, sorry, just a statement that came out from the FDA last week suggesting that the at-home tests lose a little bit of their accuracy. We've pressed for a little bit more detail about that, which tests and how much accuracy in particular. I haven't heard an update from our colleagues at the FDA on that, but what I have heard repeated by other scientists who really study this area is that even in the face of Omicron, with its mutations and variations, at-home tests, the rapid antigen tests, remain an effective tool, particularly if you're symptomatic. And Mel, if I may, right now, healthcare providers across the state are seeing a lot of folks coming in their doors in the emergency department, to urgent care, and even to primary care offices, looking for confirmation of their at-home test result. They took an at-home test, they were feeling symptomatic and crummy, the at-home test came back positive. And now folks are seeking a PCR test to confirm that. Here's the bottom line there. If you have symptoms of COVID-19 and you take an at-home test and it comes back positive, you do not need to seek confirmation of that result from a healthcare provider anywhere. You should take that result to the bank and start making sure you're isolating, staying home, wearing a mask, preventing others from being infected.
Okay, and then I do have a follow-up to that, because there are people reporting online that they have been swabbing their nose with at-home tests and turning a positive or a negative rather. They're still feeling crummy, they're still feeling worse. Then they try swabbing their throats and they come back positive. Should people be swabbing their throats with at-home test kits?
Yeah, great question, Mal, as well. So we've asked the U.S. CDC this, actually. Our top epidemiologist here at the Maine CDC put this question to U.S. CDC. And right now, the guidance remains that swabbing the nose or swabbing the throat are both effective. However, not long ago, a paper from some South African colleagues was published, a preprint was put online. And the South African researchers found just what you indicated, Mal, which is that the back of the throat swab was superior to the nasal swab. Now, the US CDC has not changed its guidance on this officially. However, the strength of the data from the South African researchers warrants consideration. And given that if you're at home, it's 6 in one, half dozen the other, no matter where you swab. If it were me, I would swab in the back of the throat, not in the nose.
Even if that contradicts what the FDA is saying about swabbing the back of your throat?
Individuals have to make a decision that's best for them. The US CDC has indicated that the nasal specimen still remains effective. There is no clear and right answer here, Mal. I'll tell you, if it were me, I would go with the back of the throat, but other individuals may decide to go with the nose.
Thank you very much, Dr. Shah.
Yep, thanks, Mal. Annie from Spectrum, over to you.
Hi, thanks for taking my question. Happy New Year. Can you remind us when you sample a positive case for a variant and where that happens and how long those results typically take to come back? And then I have a question about your answer. Sure.
Happy New Year to you, or at least it's a new year. in terms of variants, we work in partnership with the Jackson Laboratories with their supercomputing power to do the bulk of the variant sequencing. The way it works is that Maine CDC has sent positive results from laboratories across the state. We also have our own cache of positive results from the 1,500 to 1,800 tests we do every day. We take a random geographically representative sample of those positives every single week and send those to the Jackson Laboratories. That process for JAX to take those, to extract them, or what's called extract them, and then sequence them takes a couple of days. And then we publish those results usually toward the end of each week, typically on a Friday.
Okay, so do you envision a point in the near term where the state might break down Omicron and even Delta rates, like by zip code or county, the way you have for general cases? And the reason I ask is trying to get a sense of what people should be thinking about, what variant they may be at risk from, if that really matters beyond the severity of the disease, and just how people should be approaching the spread.
Yeah, no, I hear your question, Annie, and I'm going to be a little bit brusque, but I don't mean to be. The answer to your questions is no. We do not envision doing a zip code by zip code variant map. That's because given what we know about Omicron, it's everywhere. It will be everywhere. It will soon be the dominant, if not the only variant in Maine. If you are going, and so the supposition in your question that there is a differential risk profile from Delta versus Omicron is not really borne out by the data. If anything, Omicron may be a touch milder than Delta, although it's too early to say. But and we've talked about the zip code approach to risk management going back to April of 2020. It is my strong belief that if you are basing your day-to-day decisions by data that are on a zip code map, you are doing it wrong. The zip code data, as well as all testing data, as I just noted, are a retrospective look at transmission events that occurred 1, 2, 3 weeks ago. They do not tell you anything about your prospective risk.
Thank you.
Yep. Patty White, over to you.
Thanks, Dr. Shah. I wanted to get your take on the Maine Council of Churches urging congregations to switch to virtual services to preserve hospital capacity. Is that a step that churches should seriously consider, or is switching to virtual taking it a bit further than what's necessary?
Patty, I'm only aware of this development from your organization's reporting, so I haven't seen any primary documents, nor have, at least as far as I'm aware, nor has Maine CDC spoken with the Council of Churches on this. So I'm basing some of what I'm about to say just on reports. And the bottom line is, unfortunately, that there's not going to be a one-size-fits-all approach. For some congregations, going to virtual is maybe the preferred route, given the composition of their congregation. For other congregations, they may be safely able to have in-person services, provided that everyone is masked. There's not a one-size-fits-all approach, but in the era of Omicron, given that churches have been focal points for outbreaks previously, and given that, again, for some congregations, it may be an older population, that advice is conservative, it's prudent, it's the precautionary principle in action. I don't take a position on whether it should be replicated by other churches that are not part of the council. That's really for the churches themselves, but I can understand where the council is coming from. And again, given given an unknown variant with as of yet undetermined severity, that's certainly a precautionary move.
Okay, thanks. And then I've got a question about boosters for 12 to 15-year-olds. So the FDA authorized them, and then I think Maine sort of went ahead and gave permission to providers to vaccinate ahead of US CDC authorization. Can you just tell us why?
Yes, sure thing. First of all, you're correct. Shortly after the FDA's emergency use authorization came out, that afternoon, Monday afternoon, we sent a note to Maine immunization COVID-19 vaccine providers indicating that the EUA had been authorized and that they were free to go ahead and move out and begin the boostering of 12 to 15-year-olds. As you heard me note, our vaccination clinic in Augusta went out with that yesterday. There were two reasons, I guess a number of reasons, but two big categories. The first is, given the strength of the data around the importance of boosters, something you've heard me talk about, Patty, as well as the safety of boosters in this population, we didn't see a reason to wait. There was no reason to wait whatsoever. The second, and slightly more technical, is that No provider needs to wait. The US CDC's advisory committee, which is meeting right now, only issues recommendations and guidelines. It is the FDA's EUA process that is the gatekeeper. Having issued the EUA, the FDA has in effect said that this vaccine booster for 12 to 15-year-olds is safe, effective, and indicated. We didn't see a reason to wait.
Okay, great. Thanks.
Yep. Evan Pop, over to you.
Hi, Dr. Shah. Thank you. There's been some criticism of the updated US CDC guidelines, which shorten the COVID isolation period to 5 days for those with no symptoms. It doesn't require a negative test for such people. And I understand that the Maine CDC has adopted this guidance. I'm wondering, is there room for variation in state policy on this? And is Maine considering adding a testing requirement or recommendation for people to exit isolation, as some health experts have advocated for?
No, not at this time, Evan. I think the guidelines, particularly the revision last night, which provided guidance on what to do if you opt to take an antigen test on day 5, I think those are about right. I've had the opportunity to be briefed on these guidelines from the US CDC, and based on the scientific underpinnings of this, what we see is that the bulk of transmission of COVID-19 occurs on the 2 days before you have symptoms, and then the 3 to 4 to 5 days after you develop symptoms. That was the rationale for the initial guidelines to slim them down from 10 days of isolation to 5 days. I thought that was a prudent and pragmatic move. The addition of what to do if you take an antigen test, how to interpret that if it is positive or negative, I think adds further granularity. We don't have any plans right now to amplify those or make testing out a requirement.
Would you, say that it would be smart for people who have tested positive to try and access the test if they can, once they're at that 5-day point?
I think, Evan, the way that the US CDC framed it is correct, and I would go with that, which is if you do have access to an antigen test, and they are tough to find, but if you do have access to one and you take one, then this is how best to interpret it. I wouldn't say that it's a recommendation to go out and seek one or to try to purchase one. Again, that presupposes that going outside of your house is a safe thing to do on day 3 or 4. What I would urge instead, Evan, is much as we've talked about throughout the pandemic, is to take steps now to be prepared for that possibility. So hopefully the vast majority of folks who are tuned in right now do not have COVID. Now is a good time to take a minute and go to your local drugstore or pharmacy or big box store or go online and order those tests. That way, if you have them, it's that much easier to use them on day 5. If you're at home on day 5, isolating with COVID, and you have the test at home, of course you should use it.
And just a follow-up question about at-home tests. The Mills administration said last month that it would be open to applying for federal money to deliver at-home tests to Mainers. And I was wondering is that something the state has taken active steps towards pursuing, or considered using state funds to increase access to testing in that way?
Yep, it's definitely still under discussion. There's probably more to come on that soon, Evan. But no, we were still working toward acquiring more of the rapid tests for use in a variety of facilities. Our primary focus right now remains on places like schools, healthcare facilities, and congregate facilities. We're looking to see where the Biden administration's approach to acquire and distribute 1 million tests, 1 million at-home tests will go. 1 billion at-home tests. 500 million through various locales like community health centers and FQHCs, and a separate 500 million through the online portal. We think this will be a good opportunity, and we want to see exactly where that goes and when it gets online.
Great, thank you.
Yep, thanks, Evan. Chris Costa, over to you.
Hi, Dr. Shah. Got to admit, a lot of my questions have been answered already, but don't you worry. I have plenty more for you. I did get a lot of questions from viewers regarding masks. We discussed last week kind of the need to potentially retire a cloth mask if you have other options available to you. I wanted to know, this is kind of a multi-pronged question, but one, are surgical masks and KN95 masks, are those well suited for children? I know many children wear cloth masks in their school settings. The second question about that is, are those kind of elevated masks, whether it's surgical or KN95 or potentially N95, does the state have any plans to try to make those accessible to people? I know that sometimes they can be cost prohibitive. That's my first question.
Sure. Oh, that's your first question. Okay, Chris. All right. Wow. All right. Well, let me start with what I do, which is I wear a surgical mask. Generally speaking, that is the mask I've found to be effective, or certainly readily available. According to the U.S. CDC, the manner in which these are made, the fusion of various different layers, provides maximum filtering. And so when I talked last week about upgrading your mask, what I was really focused on is moving away from the neck gaiters and handkerchiefs toward either a multi-ply cloth mask, but even better, one of the standard surgical masks. That's where I'm at, and that's practice in my household. Your first question was, are they suitable and appropriate for children? The answer is yes, and they are even sized for children. Surgical masks, I bought a box for a family member of mine. Surgical masks in small sizes are available at drugstores. We found one at a drugstore in our neighborhood without any problems, or a box of them without any problems. So they are suitable and available for children. In terms of state plans, we haven't laid any plans of that sort right now, and that's largely because the masks remain available. If we get into a situation where we are looking at a shortage of masks and a broader distribution is needed, that would be a signal for us to take a closer look. But at this time, we don't have any immediate plans to engage in a wider distribution of surgical masks, or even some of the higher profile or higher technicality ones.
Okay, thanks for your comprehensive answer on that. My second question has to do with testing sites. I know that President Biden had announced, a couple of weeks ago about the opportunity to stand up more federally sponsored testing sites. Is there any news yet on if any of those will be coming to Maine? Because I know the testing is a big need right now.
It really is a big need. Let's just be straight about that. Testing is a need in Maine and across the country. We've acknowledged it. Governor Mills and Commissioner Lambrou have acknowledged it. President Biden has acknowledged it. So there's definitely a need there. Chris, we've worked with FEMA as well as the U.S. CDC, both agencies of which are managing these federal assets. We've worked with them to let them know that we need additional testing in Maine, and have offered them sites and locations. The ball is back in their court right now, so we're waiting to hear if those requests will be approved, and if so, when and for what duration. No news or announcements yet, but I'd be remiss if I didn't take another minute to let folks know that we ourselves, Maine CDC, Maine Emergency Management, the Maine National Guard, are standing up a testing site at the Augusta Armory starting this upcoming Monday.
Okay, I appreciate it, Dr. Shah. Thanks.
Thank you. Joe Lawler, over to you.
Yes. Hello. Happy aspirational new year. Following up on the hospitalization question, you're making the suggestion that would be a better day-to-day measurement. I'm wondering if, I think you probably are aware that the UK and now New York State are separating out people who are hospitalized with COVID rather than versus for COVID, and especially with Omicron wave coming. Do you think that might be a wise thing to do? Not necessarily now, but maybe a few weeks from now when we have more Omicron in the hospitals?
Yep, Joe, I don't. Yeah. So bottom line is, I think it's a discussion worth having. It does introduce. So let me first talk about it. You're right. Insofar as Omicron is likely to be much more prevalent, and potentially, although we still don't know yet, but good signs point to it being less severe. Possible that there will be more people who come into the hospital because their gallbladder is inflamed and are incidentally found to have COVID. Right now, Joe, in speaking with clinicians across the state as well as across the country, the reason we ourselves have not gone out with that distinction is that, first of all, from a health system utilization perspective, The difference between with and for doesn't matter when our hospitals are under such great strain, right? What matters right now in this day on January 5th is that the hospitals in Maine, the health system in Maine is under tremendous, tremendous strain. Whether it's because of people with COVID or people for COVID, doesn't have it's in some level a distinction without a difference. The second, though, is that I acknowledge, and I mentioned a moment ago in connection with Megan's question, that hospitalizations as a metric are better, but they have imperfections. This is one of them. But in jurisdictions and countries that have studied the distinction between with and for, they haven't found that it's made a big difference. Now that could change as we look at Omicron. The third consideration that we are weighing is that, and I've mentioned this before, every data point involves a team of people to gather the data, vet the data, analyze the data, and verify it. So if we go out to ask hospitals every single day to tell us of the 20 or 70 people who are in their beds, how many of them are there with COVID or for COVID? That's a team of people in the hospital that has to comb through each and every one of those when they're admitted to figure out what the reason for admission is. It may be epidemiologically worthwhile, but that's just we have to grapple with the fact that it's a brand new set of tasks that are going to be required at a time when hospitals are under great strain. So that's, and then the final point, Joe, that we are weighing is that although that hypothetical patient who goes to the ER because their gallbladder is inflamed may incidentally be found to have COVID, that COVID diagnosis absolutely impacts their clinical care. It changes the level of PPE that every single healthcare provider needs to be under. It changes what the surgical and anesthesia team need to keep in mind as they are caring for that patient. It changes everything. So we have to keep those things in mind. I don't know where we're going to be, but that's how we're thinking about it right now.
Okay, thanks. And I'll just ask, I have two other quick issues to bring up. One is thinking about positivity. I noticed you mentioning that the way people are utilizing PCR tests seems quite a bit different now versus, say, a few months ago or 6 months ago. Would that make it hard to compare now versus then? And then just my other topic that I wanted to bring up super quick is if cases are not as good of a way to measure the pandemic, what does that mean for schools and how they grapple with whether to keep school open in light of numbers of cases at their schools?
Great. Let me take the first one, Joe. Every single metric has strengths and drawbacks and limitations. That's just the nature of metrics, whether they are economic metrics or, in this case, epidemiological metrics. And thus, any metric that is compiled over time always has to be interpreted through the lens of what else changed around this metric contextually between time 1 and time 740, which is where we are right now. And you're right, so much has changed with testing between March of 2020 and today that saying, well, the positivity rate was 4% in March of 2020, it's 18% now, boy, aren't things a lot worse. That conclusion is a bit too quick because so much has changed. As you sort of noted, who's getting tested has changed. The way in which testing is metered out has changed. As you well know from covering the pandemic, Joe, early on, only a certain segment of people could get tested. Now it's much more wide open. We didn't have home testing back then. All of those things have changed. For that reason, when my team and I look at the positivity rate, we really look at it for how it compares to 1 or 2 incubation periods ago, not how it compares to 1 or 2 years ago, because so much has changed in the interim. Is the positivity rate meaningless? No, not at all. But it's useful less for what the raw, pure number is and more for how it's changing. What's important to me about the positivity rate in Maine over the last 10, 12, 13 days is not that it's gone from X to Y. It's that Y is so much bigger than X. The magnitude of change that's notable rather than the numbers themselves. So it's the delta that matters. To your latter question, what do we do with schools? Now, what I'm talking about when I say that cases may not be the best metric of the pandemic, that is to be thought of as a state or national level. For individual schools, workplaces, hospitals, and other places, the number of students who are in that facility or number of workers who are positive from one day to the next absolutely makes a difference. What I'm talking about, Joe, is macro level public health rather than facility by facility analysis. Let me go to Emily Bader next.
Hi, good afternoon, Dr. Shah. So I wanted to go back to the topic of the day, which is testing. I know, so Brian asked about testing in Penobscot County, I believe, but it looks like Western Maine is not really getting much love in terms of testing sites. I know Franklin County, which is not doing well at all with cases, has just one Walgreens or CVS location in Farmington where you can get a test. So are these efforts to expand testing locations extended to those areas?
They are, although, and I don't have anything to announce right now, but we are working to expand testing to maybe not necessarily to the places that you noted, but to certainly places that are within the catchment area of your paper. And that's where we're starting. We're not going to stop there because we want to keep going, but testing has been a challenge. Emily, I certainly acknowledge that. We're working to bring it to all places in Maine, Western Maine included. I'm with you. It has definitely been a desert in some places in the state. We're working on it. I'm not going to promise, though, that in X number of days, there will be a large-scale testing site in Franklin County. We're working toward those things, but it has definitely been a challenge.
Okay, and I'm wondering if you can maybe shine some light on, I think everyone's really frustrated right now. It's hard to find an appointment to get a test, or it might be hard to find a rapid test. And people are feeling like, we're almost 2 years into this, what's going on? So is it, from your perspective, is it, what's stopping us from setting up more testing sites or, any number of measures to get more tests to people? Is it staffing? Is it supply? I'm just hoping you could provide some insight.
Sure. So on the rapid tests, much of that, as you know, is managed and controlled by the federal government. The FDA being responsible for approving or authorizing the tests, other federal agencies being responsible for much of the distribution, as you heard me mention earlier, the Biden administration's plan from the White House, and then private sector entities largely being those where they're available. So the state itself isn't as involved with rapid testing, except for example, providing them to a hospital or a nursing home that's having an outbreak, or to schools if they detect positives in the pooled testing. What we have a little bit more ability to stand up is around testing sites, like the one at the Augusta Armory, which will be opening up next Monday. The challenge, however, is that a testing site needs to be operated by individuals. And right now, not just in Maine, but across the country, staffing remains a challenge. We're working to see if we can activate more members of federal healthcare partners, as well as with the National Guard. But as you've also heard us mention, there are competing priorities. If we can activate 5 more members of the Guard, should they go to a hospital to provide decompression so the hospital can take more patients? Should they go to a vaccination site so more people can get vaccinated? Should they deliver PPE, or should they stand up a testing site? Those are the very, very hard choices that we have to make to see what's best.
Okay. Last quick question. On masking, is there kind of a trick to figure out if your mask is good enough? I've seen videos, people like blowing out candles, seeing if they can do that. I think Bill Nye did that a while ago. Besides, making sure things fit, is there a good way for people to say, okay, I have this mask, is it doing a good job?
Yep. So Emily, the bottom line there is you need not go through too many gymnastics to figure out if your mask is doing a good job. If you're wearing a surgical mask or something even higher than that, then you're in good stead, provided it fits. The way to know whether it fits is to see if there are any open seams. And if there are, you can twist the ear loops or buy the bands that tighten it up. If you're not wearing a surgical mask, The easiest thing to do is to see if you can see through the mask. If you can hold the mask up and see through it and see specks of light, your mask isn't doing a good job. And that's the case for things like neck gaiters, handkerchiefs. Those are not really doing the job right now, particularly in light of Omicron.
Okay, thank you.
Thank you. And the last question for the afternoon goes to Jessica Piper.
Thank you, Dr. Shah. I wanted to just first ask about kind of the case numbers we're seeing right now. Obviously, with the positivity rate in Omicron, obviously things aren't looking good. But if I look at the graph of cases in Maine compared to somewhere like New York right now, there's a lot of places that are seeing literal, vertical increases in cases. Are we expecting that we might be seeing something like that very soon?
Yes.
Okay. And then I wanted to follow up as well on the boosters for the kids in the 12 to 15 age group. I know you mentioned the Augusta Armory is offering them. It looked like Walgreens and the big pharmacies said they weren't right now because of the US CDC recommendation. I was just wondering if you had any info on what other facilities might be offering them for parents who are hoping to get their kids those.
Yeah, we gave, after the emergency use authorization came out, providers are free to go in the direction they wish to go because it's now an FDA authorized product. We sent that notice out to let them know that Maine CDC had no expectation that they wait until after the US CDC. For the vaccine site that is most directly under our purview, which is the Augusta Armory, I asked my team to go out with it the next day at our next clinic appointment, yesterday. Other providers, they operate under their own clinical guidelines and will go out with it if and when they see fit. We're trying to keep track of that on our website, but we can't force a provider to go out with it. That at this point is their own clinical judgment. I'm hoping, and I've nudged providers to start offering boosters in this category, but ultimately they will get there when they're ready to, as well as when their IT systems, scheduling systems, et cetera, have been updated. And Jessica, as you recall, this isn't really distinct from the way that other boosters and other eligibility requirements came out. As you recall, again, you've been covering things from day one. Even when we were doing primary series shots, when we drop an age category, it often took a provider group sometimes 1, 2, 3 days to update everything, update their patient flow and their IT side. This is not really different from that. And of course, I'd be remiss if I didn't mention that the Augusta site itself at the Armory will be open tomorrow from noon until 7 p.m., offering COVID-19 vaccines at no charge whatsoever for all eligible age groups, 5 and up for primary series, 12 and up for boosters. No appointment is needed, and our team will be there from noon until 7 p.m. tomorrow. Please come in, get your booster, come in and get your primary shot. So with that, I want to thank everyone for taking some time out of your afternoon to hear where we are. Thanks to my colleagues in the media for their questions today. I look forward to chatting with everyone next week. Until then, as always, please be kind and take care of one another. We will talk to everyone soon.